Okay, it's on now. I don't know how this works, but okay, I think it's on. Yeah. Okay, thank you for your comment. Then the as we will see, the second wave also comes with problems because the typical way for regulators in this second wave to control healthcare spending is to fix the budget for healthcare. But when you fix the budget for healthcare, for example, by regulating the prices and regulated the number of treatments that can be provided in a certain year, if you restrict that, then there will be a new problem, and that is that people might not be able to get the medical care when they need it. So, for example, when the budget has been used completely, then there will be no money for additional treatments, even if people need the treatment. In other words, there will be waiting lists, and this is a typical effect that we see in this second wave, the development of waiting lists in healthcare because of the restrictions on the healthcare budget. So price controls and controls of volume and rationing, expenditure caps are not the solution to rising healthcare costs. That brings us to the third wave, which is the wave in which the regulators think more carefully about how to design the system and how to make sure that the money that we put into the system provides value, that every euro that we spend on healthcare also comes with an increase in health. And this is the complex wave that we find ourselves in now, not only in the Netherlands, but in many Western countries around the world, in which we would like to maintain universal coverage and equal access to medical care. But at the same time, we also want to introduce incentives for the patients, the consumers, those who use the medical care, but also the providers, the hospitals, the doctors that provide the medical care, and the health insurers that finance the medical care, that we try to incentivize these three parties to use the resources wisely, to spend the money on for where it's needed. So this is very complex, as you can imagine, and this will be the main question, how to do this for the second part of my talk. So if we apply these three waves to the Dutch healthcare system, what does it look like? Well, it might surprise you, but it's a fact that until 1940, so until the start of the Second World War in the Netherlands, there was hardly any government regulation when it comes to healthcare. This actually started during the Second World War, and well, in fact, our first big regulation in order to introduce universal access to medical care came from the Germans. And it was called the Sickness Fund Act. And the Sickness Fund Act in 1941 was a public insurance scheme for people who found themselves below a certain income threshold. And the income threshold was at a level where about 2/3 of the population were below and 1/3 of the population was above. And this sickness fund insurers made sure that these people, the 2/3 of the population with the lowest incomes, that they had access to curative care, so primary care, hospital care, and prescribed drugs. This was the first big step, I would say, towards universal access. The second big step was the introduction of the Exceptional Medical Expenses Act in 1968. And this was a mandatory public insurance scheme for the entire population. So not only for those with low income, but for the entire population. And it covered long-term care. So long-term care for mentally and physically disabled people. So you have to think about nursing home care, for example. And these two, big insurance programs made sure that that people had access to medical care, both curative care and long-term care. This also means that there's 1/3 of the population, those with the highest income, that had no mandatory insurance for curative care. And these people, and this was not considered a problem, because it was assumed that these people had enough money to pay for healthcare themselves or to pay for health insurance themselves. And for these people, there was the private health insurance scheme. Maybe some of you, if you're old enough, remember that we had this distinction between sickness fund insurance and private health insurance, which in fact existed until 2006, before we introduced a mandatory insurance for curative care for the entire population, as I will show you later. But these are, I mean, I can say a lot about this first wave, but these, I think, are the two real milestones in this period between 1940 and 1970. So the challenge here for the government was, okay, how to design regulation that makes sure that anyone has access to medical care. Well, then after the 1970s, there was universal access to medical care. The question came to the stage, okay, what can we do to avoid that, well, our budget for healthcare spending keeps increasing and increasing? And the answer was very intuitive. Okay, if we don't want spending to be too high, then we should restrict spending. We should restrict the budget. And there are two ways to do this, and both were applied in practice. Regulation of prices. So make sure that just fix the prices and make sure that there can be no price increases in healthcare that drive healthcare spending. And regulate capacity. So decide, as a regulator, decide on the number of hospitals that are allowed to, well, to be in the system. Regulate the number of doctors that are allowed to be in the system, etc., etc. So the combination of regulation of prices and capacity gives the regulator the tool to fix the budget for healthcare. But as I said, this created a new problem because the demand for healthcare was larger than the budget that was allowed for healthcare, and this resulted in waiting lists. And soon the regulator realized that regulation of prices and capacity is not the solution to control healthcare spending. And that brings us to the third wave. And this wave actually started somewhere around 1990. And I labeled this wave as market-oriented reforms. And it's in fact about the introduction of regulated competition, or more generally, the introduction of incentives. So if it's not a good idea to regulate healthcare prices and capacity to control healthcare spending, then the alternative that we use now is, okay, make sure that at least the people, the parties involved, the consumers, the providers, and the insurers, that they have the incentives to spend the money on where it's really needed. And that's what we are still doing since the 1990s. So what does it mean? What does this current system looks like? Let me start with a broad overview. So this overview is not only about this regulated competition, but it's about the entire healthcare financing system in the Netherlands. At this moment, we have the Act on Long-Term Care, which is in fact what I just called the Act on Exceptional Medical Expenses. This was called the AWBZ, some of you might remember, but now it's called the WLZ, the Wet Langdurige Zorg, or the Act on Long-Term Care. And this is still a public insurance, so there is no competition involved. It's a public insurance. It's carried out by what we call offices that do not bear any financial risk, that are not competing. or non-competing agencies, as you see here. And it's still mandatory for the entire population. So anyone who works or lives in the Netherlands, and I guess, well, most people in this room do, it's mandatory to pay for this healthcare scheme. And in 2020, the budget for the projected budget for this scheme is 22 billion euros, which is really a lot of money. Then in addition to this Act on Long-Term Care, there is the Health Insurance Act. And the Health Insurance Act is closely related to the Sickness Fund Act that I just told you about. But the big difference is that this Health Insurance Act, which was introduced in 2006, is now mandatory for the entire population. So the sickness fund insurance until 2006 was mandatory for the 2/3 with the lowest income. But now the Health Insurance Act, the basic health insurance for curative care, is mandatory for the entire population. Yeah, so anyone who works or lives in the Netherlands is should be enrolled in the Health Insurance Act and the Act on Long-Term Care. This is a big program. It's the biggest part of the healthcare financing system in terms of the money that circulates in the system. And it takes account of 48 billion euros in 2020. This is a private health insurance, so there's a big difference with the Act on Long-Term Care, which is a public insurance. This is a private insurance. So any individual should buy an insurance from a private health insurer. And these insurers are competing with each other. They have to respect regulation, as I will show you later. But within this regulatory framework, there is some room for insurers to compete. And that's exactly where the incentives for the insurers to use resources wisely, incentives for efficiency come in. Then next to these two big programs, there is a third program, which is smaller in terms of the money involved, but it's an important program, which is carried out by the municipalities that we have in the Netherlands. It's the Social Support Act, the Wet Maatschappelijke Ondersteuning, and the Youth Act, the Jeugdwet. And these two, for example, are from these two programs, for example, the healthcare for people who are disabled, but healthcare or help with daily activities, for example. It's not really healthcare, but it's help with daily activities. This is the type of care that is financed from this system. It's also a public program. 7 billion euros are involved in 2018. And so this is executed by the municipalities, which means that, for example, the municipality of Rotterdam is responsible for these two programs. So the municipality of Rotterdam should organize a system in which disabled people, for example, get help with the daily activities. And the choice to make the municipalities responsible for this program is that it's very close to some other responsibilities of the municipalities, which is, for example, the public environment. The municipalities should make sure that in the public environment, all people or inhabitants or all residents can participate in a way they should. And help with daily activities is also a way to let people participate in normal life. So this was one of the main reasons why the municipalities are responsible for this. Well, 10 years ago, it was the central government who was responsible for this type of care. So these are very interesting and recent reforms that we just had in the Netherlands. Then on top of this, there is the supplementary health insurance, which is not mandatory, but obviously not all medical care is covered by these well, most of the medical care is covered by these other programs, but not all medical care. For example, dental care is not, dental care for people of 18 years and older is not covered by this Health Insurance Act, and people can choose themselves to buy a supplementary insurance for this. And I guess many of you actually do. And in total, this is a program which is, well, still a lot of money, of 4 billion euros per year. This is a private health insurance, it's voluntary, it's executed by private competing insurers, and there is no special regulation by the government apart from the standard regulation that we have in in insurance markets. So this is an overview of what the current system looks like, and it's much more complex than what's on this slide, but I would say these are the 4 main categories in terms of healthcare financing. And the government, the central government, is responsible for the Act on Long-Term Care and the Health Insurance Act. The local governments are responsible for the Social Support Act and the Youth Act, and the supplementary health insurance is in fact no responsibility of the government, but it's just a free market. Okay, and what I will do in the rest of the talk, because I think this component is most interesting from an international point of view and from the perspective of the course that you are following, is the Health Insurance Act. So this is, I will take a closer look on, okay, what does this Health Insurance Act look like? How is it organized? How is it financed? And what are elements of regulation and what are the elements of competition that are used in the Netherlands? Let's start with the objectives of regulated competition, because of course, when you want to design a healthcare system as a government, you have some objectives in mind that you would like to achieve. And it's this set of objectives, I think, that makes healthcare reform so interesting. Because there are multiple objectives, and some objectives are related to what economists call fairness, and other objectives are related to efficiency. And it's this combination of fairness and efficiency that is very hard to combine in one system, as I will show you later. So what do I mean by fairness? Fairness, for example, refers to affordability of basic health insurance in case of the Netherlands, where we have an insurance scheme. So it means that, well, anyone in the population should be able to afford basic health insurance. Yeah, that's what we want, because we think that health insurance provides a very effective tool to give people access to medical care. And then the other one is accessibility of care. So even with a health insurance coverage, there can still be issues in terms of accessibility. For example, with respect to the distance that people have to travel to a hospital and the time they have to wait to get a procedure. So there might be additional regulation needed to really achieve accessibility. But these are the 2, I would say, main fairness objectives. So you want people to be able to afford basic health insurance, and you want them to have access to medical care. So what do I mean by efficiency? Well, there are multiple dimensions, I think. One thing that the government wants is that health insurers serve consumer preferences, which is not so concrete, I realize, but it means that health insurance really act as an agent for the consumer, an agent that is able to contract good quality care, to improve, to stimulate innovation of healthcare, to improve coordination of care. And your first reaction might be, wow, why is it up to the insurer to improve quality of care? Well, as I will show you later, the insurers really have tools to do this. So this is one thing. And the second one and the third one are related, of course, because consumers tend to like low insurance premiums and tend to like high quality of care. But I thought it would be good to have them as separate bullets here. It's maximization of quality given the cost. So if there's anything that an insurer can do to spend the same amount of money, but to get more quality in terms of healthcare, then he should do this. He should have incentive to improve quality, but also the other way around. When the insurer has possibilities for reducing the cost, given a certain quality level, then we also want the insurer to do this. So the insurer should have incentives, simultaneous incentives, to improve quality and minimize cost. Yeah, so these are objectives related to what I called fairness and efficiency. So in terms of regulation, what does regulated competition in the Netherlands look like? I think there are a series of regulatory tools that really are there because of these fairness objectives. One thing that if we want the population, if we think that people should be able to afford health insurance coverage, then there's only one way to do this, and that is that you have to find a way where people who do not, where people with high income pay for people with low income. That's one thing. And where people who are healthy in some way pay for the people that are unhealthy. If you don't do this, if there is no regulation but just a free market, then what we typically see is that insurers will charge high insurance premiums for people that have high expected spending. So for example, if someone has a chronic disease with 50,000 euros healthcare spending per year on average, then what an insurer in a free market will do is, okay, you can buy insurance from my company, but you have to pay a premium of 50,000 euros per year, which leads to all kinds of affordability problems, as you can imagine. This is not what we want. We want the premium to be lower for people with a chronic disease such that they can afford it. But this means that money is needed to subsidize the premium of this high risk individual, this person with a chronic disease. And then the main question when it comes to fairness is how can we achieve these cross subsidies from healthy people to sick people? And that's where some important regulatory tools come in. What we see in the Netherlands is that in this Health Insurance Act, there is a standardized benefit package, which means that the insurers, that any insurance plan should cover a certain set of healthcare benefits. The second one is that there is an individual mandate, which means that any person who lives or works in the Netherlands should buy this insurance. If we did not have this individual mandate, then some people, healthy people who do not expect any healthcare spending, they might choose not to enroll in the system because they think they will not use healthcare. They think they do not use health insurance. And this would be a problem because if only the people who are not healthy, people with a chronic disease, are in the system, then the premium will be too high. There will be no subsidy from the healthy people to the chronically ill. The third one is the requirement of community rating per health plan. And this means that insurers are not allowed to ask higher premiums to people with a chronic disease than to healthy individuals. So the premium should be the same for all. So if all of you decide to enroll in the same insurance plan from the same insurance company, then you will all pay the same premium. The insurer is not allowed to charge a higher premium to me, for example, than to you. The fourth one is open enrollment, and this means that the insurer should accept any one who wants to enroll in an insurance plan. So even people with a chronic disease for who the expected medical spending paid by the insurer is higher than the premium, the insurer must accept this person. And then a fifth one is what I call risk equalization and risk sharing. And this is, as I will show you later, a very important feature of the system that kind of compensates insurers for the predictable differences in medical spending between healthy people and people with a chronic disease. So if both pay the same premium, then we know beforehand that people, and if the premium is based on the mean medical spending, then we know beforehand that people who are healthy are profitable for insurers, and people who have a chronic disease are unprofitable for insurers. And this gives very adverse incentives to the insurer to focus on the healthy people and not on the chronically ill. Now, to avoid this, there is this system of risk equalization that subsidizes the insurer for people with a chronic disease, which means that in the end, the insurer gets more money for someone with diabetes than for someone without a chronic condition. And as I will show you later, this system is pretty crucial for this system of regulated competition to work. But yeah, I think these are the 5 elements that are pretty crucial in achieving fairness. So it's not that we can say that only one of these regulatory tools would be sufficient, but it's really the combination of these 5 tools that makes sure that anyone in the Netherlands, regardless of his income or health status, is able to buy health insurance. And in addition, as you might know, there are some cross subsidies from high income people to low income people. And this is via the financing side. So anyone with health insurance pays a direct premium to the insurer. But in addition to that, we also pay an income related contribution via our employer. And this income related contribution is higher for high income people than for low income people. So in the end, yeah, people with high income will pay more to the healthcare system than people with low income. And in addition to this, there is also support for low income people, which is called the income related allowance, the zorgtoeslag, which means that I think many of you might receive this allowance, this zorgtoeslag, which means that if you are below a certain income threshold, many students are, I think, then you receive an additional subsidy to finance the premium that you pay directly to the insurer. At least this is the idea. Okay, so this is an overview of what I think, yeah, the main regulatory tools that are in this framework of regulated competition, which are mainly there to achieve fairness objectives. So what does the financing scheme looks like? This is a simple summary of the scheme, but I hope that it's helpful for you. We as consumers are in the bottom left, and as I just told you, and as you already knew, I think, we all pay a community rated premium, a direct premium to the insurers. This premium is only paid by people of 18 years and older. So you might remember that before you turned 18, you did not pay a premium to the insurer. And also your parents did not pay your premium to the insurer. Your premium before you turned 18 was paid directly by the government, as you see on top of this figure. And as a consumer, we also pay an income-related contribution, as I just explained, and this contribution is not going directly to the insurers, but it's going to what we call the health insurance fund. And when we look at the total amounts of money that are financed with this community rated premium and with this income related contribution, then this is about 50-50. So half of the total cost in the Health Insurance Act is financed by the premium, and the other half is financed by the income related contribution. So there is a lot of money, about half of the budget, which is 25 billion per year, is in this health insurance fund. And this money needs to go from the health insurance fund to the insurers. And that is where this system of what I call risk equalization and risk sharing comes in. The amount of money from the health insurance fund to the insurers is not the same for each and every individual, but it depends on characteristics of people. So for example, this amount of money is higher for elderly people than for the young. It's also higher for people with a chronic disease than for people without a chronic disease. And as I will show you later, there is a broad series of risk characteristics taken into account for calculating this payment that goes from the health insurance fund to the insurer. It also goes in the other direction, at least at the individual level. And this is because for some people, young people, very healthy people, the expected spending, the expected cost for the insurers are lower than the premium that these people pay. And to avoid that the insurers will select these people, will focus on these people because they are profitable on average, the insurer has to pay back some of the premium to the health insurance fund. Yeah, so this means that the contribution from the health insurance fund to the insurers will in most cases be positive, but in some cases for the young and healthy people, it will be negative, which means that the insurer has to pay money to the fund. Yeah, and this system is there to make sure that in the end, the insurers receive a budget for each and every individual that matches with the expected cost of that individual. And that is very important to give incentives to the insurers to do their best for each and every individual, and not only for these young and healthy individuals that are profitable and the other guys that are unprofitable. So in fact, the risk equalization system is meant to reduce or to eliminate these predictable profits and losses that insurers have for healthy people and chronically ill. Yes, I will make this more concrete on later slides. But this is what the system looks like in general. Okay, so yeah, maybe we have to, let me see, are there questions? Because I think this is a nice a moment to have a break, because now I talked about the regulation, and from the next slide, I will talk about the competition. So where does the competition comes in? But if there are any questions about what I just presented, then maybe this is a good moment to address some of these questions before we go to the break. Okay, let me see if there is a question in the chat.
Yeah, there are two questions in the chat, Richard.
Oh, okay. Where can I see them, Jan?
If you hover over your Zoom window, you will find a...
Yeah, yes,
below
I have
you will
them.
find an icon chat.
Yeah, I have them in front of me. So, yeah, okay. So the first one was about the recording. The second one, what are some examples of the incentives that can be given to the involved parties? Perfect. This is a nice bridge to the second part of the lecture. I will talk about this after the break. So what do the incentives look like? What does competition look like? Then the third question, why do we need to have both a public and private insurance? That is a very interesting question. Because in the early 1990s, why is it an interesting question? Because in the early 1990s, the original proposal by a committee that advised the government was to integrate the public insurance with the private insurance. So not to have two separate programs, but just one program for the entire population that includes both long-term care and curative care. But in the end, somewhere along the way, this plan was not approved, and I think the main concern with this idea was that when it comes to long-term care, that there can be certain types of long-term care for which competition is not a good idea. Certain types of long-term care for which we can assume that people are not able to make appropriate choices. And when you have competition, when you want to incentivize people to make appropriate choices, then it can be a problem if people cannot do this. So for example, if there is a person with dementia, it might not be realistic to assume that this person with dementia is able to choose a healthcare provider herself, or to closely or to carefully consider which insurance plan she should take for the next year. And if she is not able to do this, there is no incentive for the insurer to really respond to the preferences of this person. So in fact, the basic point I think was that for some of the types of long-term care, competition is not a good idea. But maybe this is also a nice question to get back to at the end of the lecture, because you can decide for every type of medical care whether you think it's appropriate for competition or not. And I fully agree that there will be some differences, some important differences, which might lead you to the decision to have it for some types of medical care, but not for others. There's a new one. Okay, the last one before the break. Does the money for the Act on Long-Term Care come from tax money? And if so, does this mean that every part of health insurance in the Netherlands is income related? Yes, yeah. So in terms of the Act on Long-Term Care, it's fully financed by tax money, but I believe it's labeled. So for example, if you take a careful look at your loonstrook, paycheck, then you will see that, well, via your income, you pay taxes, of course, but you will also see that you pay a separate tax for the WLZ, the Act on Long-Term Care, and for the Health Insurance Act. So it's kind of labeled, but yes, it's fully income related. Yeah, so people who have high income, they will pay more for the public insurance scheme on long-term care than low-income people. Okay, guys, nice questions. Thank you very much. I propose that we have a break now until noon, and then at noon we start with the second part of the lecture, which will focus on the competition side of this of the Dutch healthcare scheme. Thank you. So be back at noon. Okay, welcome back. It's noon. I can hear the church bells from here. So that's for me the signal that we should start with the second part of the lecture. The first one was about the 3 waves of healthcare system reform, and one conclusion for the Netherlands or observation is that the Netherlands is in the 3rd wave, the wave where we want to combine universal access to medical care with incentives for the parties involved, the consumers, patients, healthcare providers and insurers to really use healthcare resources wisely in an efficient way. We talked about the regulation applied in the Netherlands, mainly to achieve universal access to health insurance and medical care. And now we will talk about the elements of competition. So what are the aspects of the current healthcare system that provides consumers, insurers, and healthcare providers with these incentives to work in an efficient way and to spend the money where it provides really value for money and not to waste any of these resources? We have these 3 parties for the consumer. Regulated competition is not only about insurers and healthcare providers, but it's also about consumers. In fact, it starts with the consumers, with us. And that is because we, in the basic health insurance scheme in the Netherlands, have a choice of insurer or insurance plan. We are free to decide every year, again, which health plan to enroll in for the new year. And because we have this choice, we can compare the premiums and the premiums for the different health plans. We can compare the service offered by the different health plans. We can make, as a consumer, a price quality trade-off when we choose our insurance plan. And when we actually make a careful trade-off in terms of price and quality, then this gives incentives to the health insurers to really offer a high quality insurance plan for a low premium. So to take into account both cost and quality when it comes to the design of insurance plans. So yeah, it's up to us as a consumer to make sure that the health insurers have these incentives. If we as consumers all say, well, we don't care, we just stay where we are, we do not make any careful trade-off, then there are no incentives for the insurers. But when we do, or when at least some of us do, then there will be incentives for insurers to really improve quality, maintain cost, and to be responsive to our preferences. But this is not the only, I think it's one of the major aspects of competition and choice. The second one is here between the health insurer and the healthcare provider. Like the consumer, also the health insurer has a choice or some flexibility, I would say. And this is the flexibility of choosing healthcare providers to deliver the healthcare to the consumers enrolled with the insurer. Yes, so the insurers, to make it more concrete in the Netherlands, are not obliged to contract each and every hospital in the Netherlands and each and every doctor, each and every, well, any healthcare provider, but it's up to the insurer to decide where people can have the medical care that is covered by the insurance plan. So, for example, an insurer can decide for the people who live in Rotterdam to contract one hospital in Rotterdam, but not another hospital. And for the consumer, this would mean that the consumer can have free care with the hospital that is contracted, but possibly it needs to pay some amount out of pocket when it wants to go to a provider that is not contracted. Why this aspect? Why would you do this as a regulator? Why would you give this freedom, this flexibility to health insurers? Well, to incentivize the health insurers the hospitals, for instance, to deliver good quality care at low cost, to make themselves an interesting provider for health insurers to have a contract with. Yes, so the flexibility for health insurer, the freedom for the health insurers to contract with some hospitals but not with others, provides incentives to the hospitals to deliver good quality care at low cost, to maximize quality, to minimize cost. So this is another important layer of competition. It's not only in the insurance market between the consumer and the health insurer, but also in the healthcare provider market, where the health insurer contracts providers to that deliver the care to the consumers. So yeah, this is in fact, in a nutshell, where competition comes in. And the competition is not a goal in itself, but it's used as a tool to provide these incentives to health insurers and to healthcare providers. So yeah, one additional remark that I wanted to make here is that the Netherlands, it's not that all countries that are in this third wave of healthcare reform have this system of regulated competition with health insurers and healthcare providers. All systems, of course, have healthcare providers, but not all systems have the health insurers involved. In some systems, it's only patients and providers and not insurers. These systems are also referred to as single payer national health services. And a good example of this is the United Kingdom. In the United Kingdom, for basic care, there is no insurer involved. All the healthcare is financed directly from tax money. In the Netherlands and in countries, other countries like Germany, Belgium, Japan, Switzerland, and many others, the system is different because there is a third party involved, which is the health insurer. This one is referred to as the Bismarck model. It comes from Germany. It's closely related to the sickness fund insurance that we had in the Netherlands. And the other one with the single payer national health service is referred to as the Beveridge model. So it's not true that the Beveridge model, the national health service in the UK, for example, is not in the third phase. It's also in this third wave, but it's organized differently. But also there, the challenge for the government, the British government, is to combine universal access to medical care with incentives for efficiency, but it's done in another way. Yeah, so my talk is mainly about the Bismarck model, and if there are lessons from the Netherlands for other countries, then it's mainly for countries that have this Bismarck model. So this was the simple story. This is this story was about the regulation to achieve universal access and the elements of competition that are there to achieve efficiency. In theory, it's not a very complex model, but to make it work in practice is really a challenge, and is the very reason why we started introducing regulated competition in the early 1990s, but that we are still working on this today. So it was not a kind of reform that was implemented overnight and then the other day suddenly the healthcare system looked different and it worked. No, it's really an ongoing process. And this is because in practice, there are many preconditions. A lot is needed to make regulated competition work. And what I would like to do in the remainder of this talk is to give you a flavor of what is needed to make this work. Yeah, and then this is a nice paper, I think. So according to economic theory, when you combine regulation and competition in a smart way, it's a model to achieve both these fairness objectives and efficiency. But in practice, yeah, there are some preconditions that need to be fulfilled to make the system work. And what this paper does, this paper in health policy, is that it provides an overview of these preconditions, so things that you need to make this system work. And fulfillment of these preconditions is an ongoing process. So also in the Netherlands, many of the preconditions are fulfilled, but some are not. And because some are not fulfilled, the objectives might not be fully achieved. And there's still ongoing work to fulfill these preconditions. So here is a slide. It's a lot of information. You don't have to read this now within the next couple of minutes, but it's just to give you an idea of what these preconditions are. In this paper, 10 preconditions are distinguished. A first precondition, for example, is that there really should be a free consumer choice of insurer, which means that, for example, that it's not only that it should be in the law that there is an option for consumers to switch insurance plan every year, but that also in practice, it should be able to, for people to switch. So there should be no barriers in terms of switching when people want to go from one insurer to another. I'm not going into details here, but you might be, I think you can imagine some cases where people might have the option, but cannot switch because of barriers. A second one, very important, very concrete, is that there should be sufficient consumer information and transparency. So when you want insurers to make a careful choice of insurance plan, to take into account the premium of plans and the quality of plans, then consumers should have information about the premiums, which is generally not a problem, but also about the quality. And what is the quality of a health plan? When would you say that the health plan has high quality? When it has low quality? This is very difficult, and it needs a lot of time and efforts to be able to label insurance plan as high quality and low quality plans, and then to explain this, to provide this information to consumers in a transparent and understandable way. So when it comes to the quality of health insurance plans, for example, an important parameter might be, okay, which hospitals are contracted? Are the high quality hospitals contracted or only the low quality hospitals? This could be an indicator. And as you can imagine, this is very difficult, because then you also need information on what is a high quality hospital and a low quality hospital. So I think this is one of the major ongoing challenges to make explicit the quality of healthcare in a first step, and then in a second step, the quality of insurance plans, and then to present it in an understandable and transparent way to consumers, because consumers need this to make careful trade-offs. And you see some other examples here down the list, but this is just to give you a flavor that, yes, of course, you need good information, you need a lot of other things to make this work in practice. And then the conclusion of this paper, it compares the Netherlands, Belgium, Germany, Israel, and Switzerland, that for all these countries, some preconditions are fulfilled, but also other preconditions are not fulfilled or not at all fulfilled. So all these systems that have some form of regulated competition are not yet there. And this is also true for the Netherlands. And I will explain in a couple of minutes in a little bit more detail what the main existing problems in the Netherlands are to make the system work. Okay, so does regulated competition work in the Netherlands? I think from an analytical point of view, and I will show this later, we can conclude that not all preconditions are yet fulfilled. But apart from this question, does regulated competition indeed achieve the objectives related to fairness and efficiency? That's a very interesting question. This is my opinion. My opinion is that the system in the Netherlands indeed achieves the fairness objectives. So in the Netherlands, anyone, I would say, is able to afford basic health insurance coverage in the current scheme with all these regulatory tools that I presented. It's possible for people who have a chronic disease. It's also possible for people who have low income. Because of health insurance and also because of the structure of our healthcare delivery system, I would also say that healthcare is very accessible in the Netherlands. Anyone can get the care, can afford the care, but also can get the care within a reasonable distance and waiting time. So these fairness objectives, I would say, are really achieved. They have been achieved for a couple of years. When it comes to efficiency, however, I think it's a different story. To some extent, yes, efficiency objectives, well, are achieved, but there are also examples of where they are not fully achieved, where there is potential for improvement. So do insurers serve consumer preferences? In part. Do insurers maximize, is there maximization of quality given cost? Partly, I would say. Is there minimization of cost given quality? Also partly, I would say. Why partly? Why is this not fully fulfilled? Well, it's because of a couple of problems that I will present you later. Why is it partly fulfilled? So where does it work? When we look at the competition side, then we see that every year, indeed, consumers switch plans. So not all consumers, but 1 in 20 or 1 in 10 consumers actually does. So here we see that for 2020, 6.5% of the population actually switched insurer. This is not a very high number, but this number is about more than 1 million individuals every year. And 1 million individuals switching health plan every year provides a real incentive to insurers to really try to get these people, to let these people choose for them. So yes, it's not a really high number, but I would say it's sufficient to really provide insurers with effective incentives to improve quality and maintain cost. Signals of price competition, I think there are, because in many years, when we look at the past 10 years, in many of these years, insurers charge premiums below cost price. And they were able to do so because the insurers, or most of the insurers, they had high financial reserves. And the financial reserves were higher than strictly required by the insurance regulation. So they were able to use some of these reserves to charge a lower premium, a premium below cost price. Why did they charge a premium below cost price? Because they really felt it was needed to have a relatively low premium to attract new people and to keep the existing customers. So this, I think, is a strong signal that indeed insurers try to minimize their premiums, which is good from a competition point of view. Another signal of price competition, and that this can work, is that insurers have succeeded in bringing down prices of specific drugs. So insurers, they negotiate with pharmaceutical companies on the price of drugs. And when we look at the past 10, 15 years, then we see with this system of regulated competition that for some of the very expensive drugs, prices indeed went down. So here we can say that, okay, well, it's pretty nice to have the insurer involved in this system as a kind of agent that on behalf of the consumer negotiates with healthcare providers, pharmaceutical companies in this example, to bring down the price of medical care. Then another signal is that we also see a trend towards global budgets for hospitals. So it used to be, hospitals used to be paid on the basis of fee for service, which means that for each additional treatment, the hospital got an additional amount of money. From an economic perspective, this might not be a good, not provide a good incentive to hospitals, because when you are paid fee for service, when you know that when you produce more, you will get more money, there is a financial incentive to do more and more and more. There might be even an incentive to do more and more and more when it might not be needed in terms of healthcare needs. So in that case, it would be a waste of money to have additional treatments when you think these treatments are do no longer provide any value. So from an economic perspective, it would be better if insurers take a close look together with the hospitals at the expected spending of the hospital and the amount of money that the hospital needs to really, well, provide good quality care. And instead of fee for service, to pay the hospital with a global budget. And this is exactly what happens today. So today the insurers negotiate with the hospitals about the total budget, for example, for next year. And then this provides an incentive to the hospitals to really work in an efficient way, because when you know beforehand what you will get in terms of budget, then you have an incentive to keep your cost below the budget, to stay within the budget. So if it's possible for you as a hospital to make efficient choices, to save money, you have this incentive in a budget system. Because, yeah, the idea is that if, in the end, if your budget was higher than your spending, then you can get, you can keep the savings. Yeah, this is different from a fee-for-service system. This is just a first step, because in the end, what we would like to see in the current system is that the money that the hospitals receive, the budget, is not only related to the expected spending of the hospital, but also related to the outcomes of the hospital. So when you have two hospitals with exactly the same expected spending, you would give them the same budget, but if you know that one hospital provides higher quality than the other hospital, you also would like to give a higher budget to that hospital. So not only to incentivize hospitals to control costs, but you also would like to incentivize them in the payment system to improve quality. So some important steps have been made, but we are not yet there. Yeah, and this is exactly my point. So we see signals of price competition. We see signals that insurers and healthcare providers take into account prices when it comes to decisions, for example, in terms of contracting and the delivery of care. But we do not yet see signals or real signals of quality competition. And the reasons for this relate to the preconditions that I just told you about. One potential explanation is that what we see in the Netherlands, that consumers tend to distrust insurers. So consumers tend to put more trust in the healthcare providers than in insurers. And this is a problem for health insurers, because if health insurers are supposed to negotiate with healthcare providers to improve quality of care and reduce spending, then they do this on behalf of the consumers. If the consumers do not trust the insurers, there can be a problem. For example, when an insurer decides not to contract a hospital that provides relatively low quality, or a hospital with high spending, given the quality level, then it will be difficult to explain this to the consumer if the consumer does not trust the insurer. This is actually what we see in the Netherlands. Not all consumers, but many consumers do not understand why insurers do not contract specific hospitals. This is also some kind of information problem. Consumers are not fully aware of the role that insurers have in this system. And this makes it difficult for insurers to really say, well, I have only contracted some hospitals, it's for you consumers, where consumers think, well, no, it's a problem for me if not all hospitals are contracted. So this is an important issue that needs to be solved, I think. Second one is that, well, as I already told you, at least a little bit, is that the information on the quality of care is still insufficient. So at this moment, it's not clear, at least I would say for most of the treatments in healthcare, what the quality of these treatments is. So what the outcome of these treatments is and what the differences in outcomes are between provider A and provider B. And this is problematic for two reasons. First, if information on quality is insufficient, then it will be more difficult for health insurers to decide with which hospital to have a contract and with which hospital not to have a contract. So in the healthcare provider market, the market between the insurer and the provider, this is a real problem if we want insurers not only to take into account cost, but also quality. But also in the health insurance market, where people choose their insurance plan, this is a problem, because if you want consumers to take into account both the premium and the quality of the insurance plan, you need to know the quality of the underlying hospitals that have been contracted for the plan. Yeah, so competition comes with choice and flexibility, but it's based on the assumption that there is information to make careful choices. And if the information is not yet there, there's a problem. And this is one of the ongoing issues that need to be solved, not only in the Netherlands, but in all these healthcare systems with regulated competition. Then the third one, and that one I think is a nice one to look into, because it shows how complex implementation of regulated competition is. And this third problem is that there are still some groups of people in poor health, people with a chronic condition, that are unprofitable to insurers. And if insurers know, for example, that people with diabetes are unprofitable, that if the insurer attracts more of these people, that there will be a predictable loss for the insurer, then what is the incentive for the insurer to really do his best for this group, to really improve the quality of care of diabetes care, to improve coordination of diabetes care? This is a problem that many people do not see, many consumers of course do not see, but it's a problem somewhere in the back office of healthcare financing that needs to be solved. And because it's in the back office, it's not visible to most people, I would like to go in a little bit more detail to make it more concrete to you. So this has to do about risk selection, and risk selection for an economist like me is a very nice topic because it makes health insurance so interesting. So what's the problem here? Well, the Netherlands, but also all these other schemes, they rely on premium regulation, which means that in the Netherlands, the premium should be the same for anyone with the same insurance plan. This was part of the regulation, as I told you. And of course, the premium regulation is there because of fairness. We do not want people with a chronic disease to pay a higher premium. But if the premium is the same for both healthy and chronically ill people, then there is an incentive for the insurer to select the healthy people and not to select the chronically ill. This is called risk selection. And this problem needs to be solved by what I called risk equalization, the compensation that insurers receive for people with a chronic disease. The compensation from the health insurance fund that is higher for someone with diabetes than for someone without a chronic disease, for example. But this system, which is now, which was introduced almost 30 years ago, is still work in progress and does still not fully compensate for these differences in expected spending from the insurer's point of view between healthy and unhealthy people. Yeah, and to give you an idea, so this is where the risk equalization was in the financing scheme. So it's between the health insurance fund and the insurers. And to give you a little bit more information on what this system looks like, believe it or not, oh, here it is. So what are the characteristics that insurers, that the compensation for insurers is based on? They are here on this slide. It's, I would say, two sets of information. The first one is based on demographic and socioeconomic information, and the second one is based on what I call here morbidity indicators, more direct indicators of health status. So in terms of demographic and socioeconomic variables, information included is age and gender. So the compensation that an insurer receives is higher for elderly people than for the young, and in some age groups higher for women than for men. Something that has to do with region is included. Source of income is included, which makes a distinction, for example, between people who are self-employed and people who receive a disability allowance. Socioeconomic status is included, level of education is included, household composition, single household versus non-single household, and being institutionalized. And I will not go into too much detail, but this information is operationalized in certain criteria. And these criteria are used for each and every individual. So me, but also you, in this system, the regulator knows exactly what your age, gender is, from which region you are, what your source of income is, etc. And based on that information, there is a calculation of the compensation for your insurer. Then the direct indicators of health status. These are meant to get an indication of someone's expected healthcare spending. So as you can imagine, people who have a chronic disease have higher expected spending than people who do not have a chronic disease. So how can we know whether an individual has a chronic disease or not? And if the individual has a chronic disease, what the chronic disease is, which one? So this information is used to get exactly that indication. First, prescribed drugs from the prior year. So specific drugs can tell you that people have a certain condition. For example, if people used insulin, quite an amount of insulin in the prior year, then it's very likely that that person has diabetes. And there are other drugs that are specifically related to chronic conditions. So you can use drugs as an indicator for health status. Same is true for hospital procedures. If people got specific procedures last year, that might tell you something about health status. Might also be true for medical equipment. If people used certain durable medical equipment, this can tell you something about the condition that they find themselves in. Also, the physiotherapy diagnosis. If people have physiotherapy for a certain chronic disease, then this will be known to the physiotherapist, and this will also be known to in the data from the physiotherapist. And then there are indicators based on spending. If you know that someone has high spending in each of the 3 preceding years, then probably that person has a chronic disease. So it's not as concrete as with prescribed drugs, for instance, but it's also an indicator whether a person, is healthy or not. So this is just to give you a general overview. Yeah, this type of information is available for each and or for the regulator, information about each and every individual in the population and in this room to get an indication of his or her health status, which is used as a basis for the payment to the insurer. Pretty scary, right? That the regulator has all this information. But yeah, it's good. It's used for a good cause. So with this system, how good is this system? When we use all this information, is the system able to really compensate insurers in an adequate way? Or are there still groups in the population for which the insurers have a predictable profit or a predictable loss? This figure here gives you an answer to this question. What we see here is the mean profit or loss for insurers for 3 groups of people. Well, you can skip the bottom group, the missing group. Let's focus on the top 2. It's a group of people that indicated in a health survey that their health status is good or very good. It's about 3/4 of the population. And the group that indicated that the health status is fair, poor, or very poor. So this is this general question that you also, I think, once have been asked in a health survey. How would you rate your health status? Very poor, poor, fair, good, or very good? Well, this is the result of that question. And based on that information, we made a distinction here between these 2 groups. Then the white bars, they show the mean financial result for insurers per person per year when there would be premium regulation, so when both would pay the same premium, but no risk equalization. So in this scenario, the insurer would receive the same amount of money for both groups without an additional compensation from the risk equalization system. And then we see that for people who are in good or very good health, the insurer has a huge predictable profit. For each person, on average, the predictable profit for the insurer is 1,114 euros per year. And there would be a huge predictable loss per person per year for those who are in poor health, 3,355. Now, this is exactly what would lead to wrong incentives, because when this would be the situation, the insurer would really have an incentive to select only the people in good health and to try to keep away all the people in poor health. That's why we have risk equalization. Now, if we apply risk equalization, what would happen with these predictable profits and losses? And that's shown by the blue bars. And as you can see, because of risk equalization, the blue bars are closer to zero, much closer to zero than the white bars, which means that risk equalization reduces the predictable profits and losses for the insurers. So the incentives to do risk selection are really reduced by this system. But even with this system, we see that the people in good health are profitable to the insurers, 187 euros per person per year. And those in poor health are unprofitable to the insurers, a loss of 512 euros per year. So even in the current system, the incentives for insurers to be responsive to people in poor health are insufficient. Yeah, and this, I think, I hope gives you a flavor. I mean, this is a story in itself, this risk equalization, but it gives you a flavor of how difficult, how challenging it is to get the incentives right. Yeah, you need good information, as I just told you, but you also need a good risk equalization system, as we see here. Because with predictable profits and losses in your healthcare system, there will be an incentive for insurer to do risk selection, which is not nice. And if insurers have these incentives, they also have, at least in the Netherlands, tools to respond to these incentives. And all these incentives come with negative effects. So for example, if we know, and this is the case, that people with diabetes are unprofitable to insurers, then insurers have insufficient incentives to really improve the quality of diabetes care. Because if they would improve the quality of diabetes care, and if they would say in November, people with diabetes, please come to me, come to our health plan, because we have the best quality of diabetes care, then the insurer has a problem, because these people come with a predictable loss. So this is not really, it's not that we should blame the insurers, but we should blame the system. The system does not provide the right incentives. So it's important to get the incentives right as soon as possible, such that we will see that insurers actually start to be responsive also to people with a chronic disease and not only the healthy ones. So risk selection has negative effects on fairness and efficiency, and that's exactly what we not want with the healthcare system. So I realize this is a lot of information, and for someone who is not familiar with risk equalization, it might be hard to follow, but I hope that at least I gave you a flavor of the complexity of implementing regulated competition in a way that it actually works. So this brings us to the end of the lecture. Before I summarize, I think I need to check the chat. Yes, there is one question. How does the government make the health care insurance and care affordable for homeless people who have very little or no income? Is this also with the insurance allowance? Very good question. Yes, if you are homeless, then the allowance that you receive from, and if you have no income, then the allowance should be high enough for you to buy your premium. But as you can imagine, for these people, problems are so big. If they receive an allowance for healthcare in January, it's unlikely that they will save this allowance to pay their premium. They will probably spend this allowance on other things. So homeless people, I would say, are a problem in any system, and also in the Dutch system. So I did not include this in my talk, but in the Netherlands, there is still a group of people, I think it's around 150,000 individuals who does not have health insurance. And in this group, there are also homeless people who might not even know that they need health insurance. And if they know, they might not be able to afford it. These people, they will depend on the healthcare system. And what we typically see is that, of course, because it's in our law that anyone with a medical need should get a treatment, independent of his or her situation, they will receive the treatment when they go to a hospital. But then the question is, for the hospital, who should pay for this? And in some cases, the hospital will pay directly. In other cases, when it's a very expensive treatment, what we see sometimes is that the hospitals buy insurance for this specific individual. So, for example, if there is a treatment of 20,000 euros needed to help a homeless person, then it will definitely be worth the cost for the hospital to buy an insurance plan for this person of 1,000 euros per year to get reimbursement for this treatment of 20,000 euros per year. This is still one of the flaws or questions in our systems. How can we deal with this? But it's possible because it's not only the individual himself that can buy an insurance plan, but you can also buy an insurance plan for another person. But if you buy the insurance plan for another person, the other person is insured, but you as the insurance taker has to pay the premium. So in the example that I just gave you, the hospital will buy the insurance for the homeless person, and the hospital will need to pay the premium, but the hospital is willing to pay the premium because that also means that the hospital will get reimbursement for the high cost procedure. So a very nice question, but it really goes into the details of the healthcare system. Yeah, it was not included in my talk, but yeah, it's a good question. Okay, so some key takeaways, just a summary of what we did this morning. Yeah, I told you about the 3 waves of healthcare system reform that you can apply to the Netherlands, but I know that there are people in the room from other countries, and you can apply these 3 waves also to your own country. And most of the Western countries are in the 3rd wave, but we can also find countries around the world that are still in the 1st wave, that are working on universal access to medical care, where the situation is very different from what we have in the Netherlands. And it might take ages before these countries find themselves in the 2nd or the 3rd wave. But the 3 waves are the typical path of healthcare system reform, which is very nice way to characterize it, I think. So since the 1990s, the Netherlands is in the 3rd wave, and this basically means that the biggest change that we have seen is in the curative care sector, which is now organized around principles of regulated competition. I've shown you what regulated competition means in theory. So what are typical regulatory tools? Where does the regulation come in? And I've also discussed with you that regulated competition in theory might be a very nice model, but is very complex to implement in practice because of these preconditions, things that you need to make the system work. And because of this, I think there is a lot to learn from international experiences. So countries can learn a lot from looking at the challenges faced in other countries. And that's also the reason I think that the course that you are just doing, this course is very interesting, and I hope you get a lot of fun with the other lectures that will follow. So thank you for listening. Good luck with the course, and yeah, maybe one day we will meet and discuss about the ongoing challenges in healthcare system reform. Thanks, guys.
Sorry, I have another question. I didn't put it in the chat because I didn't know how to explain it, but I had a question about the accessibility of the care. Because there was a time ago, there was a problem that a lot of general practices were full, and not everybody could enroll in those general practices. So how does the government solve that for people who cannot enroll in those general practices?
Yeah, that's a very interesting question. So indeed, because this is about access, it's the responsibility of the government to solve this problem. Yeah, there can be issues from time to time, and it's then up to the government to solve this. And in this special case, I would say if there are not enough doctors, primary care physicians, or maybe other doctors that are needed somewhere, then it's up to the government to try to get more doctors in the market. Yeah, and for example, that can be done by how is this? By promoting like courses that you are following for medical doctors and teaching programs to help more people to choose this profession. Yeah. But you are right. In that case, there is a responsibility for the government. It's not up to the doctors. It's not their problem. No, it's a responsibility of the government, because the government is responsible by law that people can obtain care when they need care. Yeah. Any other questions? If not, then we can close the session and have some lunch. Okay, bye guys. Jan, ben jij daar nog? Jan, ben jij nog aanwezig?
Ja, ik ben er nog.
Oké, nou, volgens mij ging het prima. Ja, het is een beetje raar. Het blijft toch raar hoor, want ja, je kan de studenten niet aankijken, dus je hebt geen idee of er misschien nog vragen leven of niet.